Hi guys, today we're going to talk about diabetes mellitus and the way that we can treat diabetes. There will be two parts to this lecture. This first part is going to introduce the disease of diabetes mellitus and talk about the way that we can use insulin, exogenously, injected insulin, in order to treat type 1 diabetes or type 2 diabetes that has progressed to the point of the patient needing insulin. The second part of the lecture, or the second video, is going to cover all of the other agents that we use to treat diabetes mellitus. There are a few other parenteral or injectable agents, as well as oral agents like metformin. So first, before we talk about diabetes, let's just take a second to talk about the way that the body usually controls blood glucose, because that's what diabetes is. Diabetes is when the body is unable to control serum glucose levels, and so they get very high. So typically, the pancreas is one of the most important organs that's involved in controlling blood glucose levels. If you look here at the picture, you can see the pancreas, which is where we release the two hormones that are mostly in charge of controlling serum glucose. Those two hormones would be glucagon and insulin. When we look at the pancreas, most of the pancreas is actually exocrine in function. So most of the pancreas is taken up by the cells that produce pancreatic juices that are important for digestion. However, also inside the pancreas, we have little areas that are called islets of Langerhans. And that's what you can see here. These islets of Langerhans are the endocrine cells that release hormones. Now there are, D cells that make somatostatin. That's not really what we're looking at right now. What we're looking at mostly right now are the alpha cells and the beta cells. These alpha cells and beta cells are most important because those are the cells that make insulin and glucagon. Alpha cells make glucagon, beta cells make insulin. Okay, so if you look over here at the right, you see, of course, the pancreas is where we're going to get those hormones, glucagon and insulin. And then also you'll see the liver over here. The reason we look at the liver is because the liver is where we store excess glucose. So the liver and the muscles. But when we're talking about blood glucose, we're really looking at the liver here. So you eat a meal and your serum glucose goes up, right? You absorb a bunch of sugar from your GI tract. And what you need to do is store that sugar so that you can access it later. Where do we store it? We store it in the liver as glycogen. So when we have a bunch of glucose, all of those glucose get hooked together to make a big, huge glycogen molecule. And then we store that glycogen in the liver. 6 hours goes by, we haven't eaten anything else. All of the blood that we had, all of the glucose that we had in our blood has gotten used up by our cells. At that point, we need to take that stored glucose out of the liver. So, we go to the liver, we break down all of that glycogen into little glucose. Those glucose get released into the blood, and then we can use them. So we're constantly going back and forth depending on when the last time we ate was. We have a lot of sugar, we put it in the bank, right, the liver. We don't have a lot of sugar, we take it out of the bank, right? We're constantly going back and forth. Now, the way that the body knows which of those we need to do, right? Do we need to convert glucose into glycogen to store it, or do we need to break down glycogen to take the glucose out? The way the body knows which one of those to do is based on what hormones are present. So again, we have insulin and we have glucagon. Those go to the liver and those talk to the liver to tell the liver what it should be doing as far as that glucose goes. And there are, a few more steps to it than that. We'll talk a little bit more about insulin in a second and all of the actions of insulin because there are a lot. But that's kind of the overall gist as far as what's happening with either storing glucose or getting it out of storage. So here you can see when we have high blood sugar, so just after a meal, that causes the pancreas to release insulin. So you can see, like, following all the red arrows, we release insulin. We have a lot of sugar in the blood, so insulin is going to work to decrease the amount of sugar that we have in the bloodstream. And it does that a few ways. Insulin goes to the liver and it tells the liver, we have plenty of glucose, let's convert that glucose into glycogen so that we can store the glucose for later. Right? So that increases glucose into glycogen. Insulin also is involved in allowing our cells, our body cells, to take up that glucose. So there are some glucose transporters that are not present and active in the cell membrane unless insulin is present. So when we have insulin released, it goes to these cells and it causes the cells to activate glucose transporters so that glucose can be taken up into the target cell so that cells can use all of that glucose that's available. So here you see, target cells. So sugar goes into cells, sugar gets stored, and overall that lowers blood sugar back to normal. The opposite of this is low blood sugar. Right? Again, you haven't eaten in a long time. The amount of sugar in your blood drops. The pancreas responds to that by producing glucagon. This glucagon that comes from the alpha cells of the pancreas goes to the liver, and it allows us to take that glucose out of storage in the liver. So glucagon stimulates the breakdown of glycogen into glucose and then releases that glucose into the blood, and we are able to increase our blood sugar back to normal levels. Now, when we talk about diabetes, diabetes is a heterogeneous group of diseases or syndromes that are associated with hyperglycemia. So when you say that somebody has diabetes mellitus, you're saying that they have some sort of disorder where they're unable to regulate their glucose levels and they have high blood glucose. Patients with diabetes have either less effective insulin, so they might make insulin, it's just that their insulin doesn't work very well. Or they might not make enough insulin. They could have a relative lack of insulin, like they make some but not very much, or they could have an absolute lack of insulin, where their beta cells have been completely destroyed and they cannot produce insulin. So there's a whole range of symptoms, or a whole kind of range of severity. Maybe their insulin just doesn't work very well. They have some insulin resistance. Maybe they don't have quite enough insulin. Maybe they don't have any insulin. But a lack of insulin leads to an inability to move glucose into cells. Right, so that's a major problem. Remember, we need insulin to open up that transporter so that glucose can go into cells. So without insulin, your cells are starving for sugar, which seems odd because your blood sugar level is really high. So it seems like you have a ton of sugar. Why are your cells starving? Well, they're starving because even though you have a lot of sugar, you can't actually bring it into cells. So an inability to move sugar into cells to use. Also, an overproduction of glucose in the liver because you're not able to use glucose, right? So your body thinks, wow, I'm starving for sugar. Let me make some more. So gluconeogenesis, making new sugar happens in the liver, which just makes the problem even worse because you already had high blood sugar. Now your blood sugar gets even higher, and that's problematic, right? Having too much sugar flowing through the bloodstream damages small vessels. That's why we don't want this hyperglycemia. Too much sugar in the blood damages the vessels. So damages, tiny vessels. And uncontrolled, lasting hyperglycemia can lead to retinopathy. This is one of the leading causes of blindness. Nephropathy. So we see kidney disease, kidney failure, or renal failure that can occur because of uncontrolled diabetes. Neuropathy is very common. So, patients will lose feeling down in their limbs. And then, various cardiovascular complications. Also, uncontrolled hyperglycemia is commonly associated with amputations of the limbs because there is a lack of blood flow to that area, which causes very slow wound healing. So impaired wound healing. And that combined with the neuropathy is a really dangerous combination because patients will get a little cut or a little blister, on the bottom of their foot, and they won't feel it because of the neuropathy. They have no feeling. So they don't know that there's a wound there. Well, there's impaired wound healing, so that wound doesn't heal. It doesn't get better. It festers and gets worse and worse and worse, and the patient has no idea that that's happening. And eventually the wound can get down to the bone. It can get really severe to the point to where the patient actually has to have, the limb removed, has to have it amputated. So uncontrolled hyperglycemia or uncontrolled diabetes mellitus is very dangerous. Patients might not feel bad initially, but it's important for them to understand that this can cause blindness, kidney failure, amputations, etc. So we can see a few things here on this slide. First, here on the left, you guys can see the comparison between type 1 diabetes mellitus and type 2 diabetes mellitus. Type 1 diabetes mellitus is usually caused by the autoimmune destruction of beta cells in the pancreas. So autoimmune meaning the patient's own immune system attacks the beta cells and destroys them. So once the beta cells are destroyed, the patient cannot produce any insulin any longer. So type 1 diabetes is characterized by a complete lack of insulin production. So patients require insulin injections daily, either an insulin pump or multiple daily injections of insulin to try and mimic what the body would normally do, which we'll talk about in just a second with this other picture. Now, type 2 diabetes is not autoimmune. Type 2 diabetes is usually caused because the beta cells are unable to keep up with the need for insulin. And it usually begins with what we call insulin resistance, where where patients produce insulin, but the insulin is not able to work as well as it should. Usually, this is associated with obesity. So you can kind of think of it like overuse, right? If the patient has a poor diet with a lot of carbohydrates, you can think of it like they're constantly having insulin bind to the receptor to activate these glucose channels all the time. It's happening. And after a while, the body kind of becomes slack at responding to this. It's like, oh, insulin's here again. Great. Let me try and open up this glucose transporter. And it doesn't happen very well anymore. So even though the pancreas is producing insulin, that insulin's not activating that glucose transporter very well. So that glucose is remaining in the bloodstream, and there's high blood sugar that's present. So the pancreas, tries to produce even more insulin. So the result is, the pancreas has to work extra hard in order to get enough insulin to move that sugar into the cell. And then over time, the pancreas starts to get worn out from this, right? Like the person's insulin resistant, so the pancreas has to work overtime to produce more insulin. And ultimately, with type 2 diabetes, if it's not controlled well, and it's allowed to just continue on its own, it can worsen to the point to where the person is not able to produce insulin anymore. The pancreas can be so worn out that it stops. And at that point, the person, it can progress to where the patient does need insulin injections. So type 1 diabetes, they always need insulin injections. Type 2 diabetes, insulin injections are typically not required in the beginning, but if it's not well controlled, it can progress to the point to where the person does need to inject insulin. Type 1 diabetes is generally present in childhood. It generally presents earlier than type 2 diabetes. Type 2 diabetes is usually presenting later in life, like in the 30s or so. Although with the increase in childhood obesity and the worsening of the diets in American culture, we are seeing type 2 diabetes in younger and younger patients. Also, when we look at weight, again, type 2 diabetes is generally associated with obesity. Type 1 diabetics are actually underweight. Frequently, type 1 diabetes is associated with weight loss. So that's a big distinction between the two. Type 2 diabetes is much more common. The vast majority of diabetes that we see clinically is type 2 diabetes. Also, like just kind of symptom-wise, we see patients present with polydipsia, polyphagia, and polyuria. So polyuria is urinating a lot. Polydipsia is being very thirsty, and those two kind of go hand in hand. And then polyphagia is, being hungry. And all of that's related to the sugar. If you can't get your sugar into cells, your cells are starving. They think they need nutrients, so that stimulates hunger. The polyuria is because of the glucose in the urine, and that's another thing that we'll see. We'll see glycosuria or glucose in the urine. The glucose in the urine is because typically all of the glucose that gets pushed out into the capsular fluid in the nephron, all of that glucose should get reabsorbed back into the body, right? We don't urinate out nutrients. We reabsorb all of those nutrients out of the urine back into our body. But when we have so much sugar present, we overwhelm the transporters and the body can't keep up, right? The body's not able to reabsorb all of that sugar, and some of the sugar remains in the urine and leaves the body in the urine. So we see sugar in the urine. Now remember, water follows solutes. So usually we would reabsorb all that sugar and some water would follow via osmosis. But when we are not reabsorbing that sugar, when that sugar stays in the urine, that increases the osmolarity of the urine, and that pulls water into the urine. So we have increased volumes of urine being produced, hence polyuria. And that means we need to drink more to replenish that fluid. This is why the polyuria, that's where the diabetes term is coming from. Remember, there's diabetes mellitus and diabetes insipidus. They're both associated with polyuria. Diabetes insipidus has nothing to do with blood sugar, right? Remember, that's when the person doesn't have ADH and they're unable to regulate their urine and they produce a lot of urine. So don't confuse the two. This is diabetes mellitus that's associated with hyperglycemia or high blood glucose. Okay, this second picture here is looking at insulin release and how insulin is released in normal patients versus type 1 diabetics and type 2 diabetics. So this blue line is showing us normal insulin release. Notice that there is a constant basal release of insulin. In normal patients, insulin release never goes down to 0. And that's so that we're always able to move some sugar into our cells and to prevent the body from going into this phase where it thinks it's starving and there's no sugar available. Because in that state, the body starts to break down, all of our stored fats and proteins. So we have lipolysis and proteolysis, and the body starts to break everything down. So that basal release prevents that from happening, and prevents glycogenolysis and gluconeogenesis in the liver as well. Just essentially allows us to use the sugar that's already present in our bloodstream. So there's always this basal release of insulin. Then after we eat a meal, you can see like right here at this point, this is an infusion of glucose. So we eat, we've got a bunch of glucose available. Normally within 2 minutes of eating, there's a burst of insulin secretion. So that's what you see here. This big upstroke on the graph is this burst of insulin secretion that occurs. That lasts up to about 15 minutes. And then that's followed by postprandial secretion. That's not as high as that peak, but still higher than the normal basal release. So that's what you see here. There's like this big peak that occurs, and then it goes down a little bit, but we still have higher postprandial, which is like after the meal, release of insulin for a little while, and then it'll go back down, to normal levels. So couple minutes, a big peak, that insulin that gets released, takes us through like 15 minutes or so, but then postprandial, we continue to release for the next 5, 10, 15 minutes. We continue to release at a higher level. This red line is showing us what happens in type 2 diabetics. Type 2 diabetics are still, able to release some insulin. It's just that they generally don't have the same peak capabilities that we have. So you do see there is a basal release of insulin. You still see after a meal, it increases, right? This red line goes up. They do release more insulin after a meal. Again, it's just not the same levels that we see in a healthy pancreas. And then in a type 1 diabetic, down here at the bottom, notice there is no insulin release. No basal, no peak after a meal, no insulin release at all. This slide shows us the way that type 2 diabetes progresses from a point of just having some insulin resistance all the way to the point to where they're not able to produce insulin any longer. This first picture here is kind of showing us this cycle, how insulin resistance leads to damage to the pancreas and an inability to produce insulin. So first, we start up top with number 1. We start with insulin resistance in our peripheral tissues. So we have insulin, but it's not working in our peripheral tissue. So our tissues are not able to move that glucose into the cells. So the body's response is, oh, my cells can't get glucose, let me make more glucose. So we have increased production of glucose from the liver, and that increases this hyperglycemia that we have. Here you see our cells are not able to actually use that glucose very well because there is insulin resistance, right? The insulin that's there doesn't work. So all of this glucose that's flooding into the bloodstream has a really hard time getting into our cells. Now, this leads to, the pancreas trying to produce more insulin to keep up with this need to allow us to use that glucose. Over time, the pancreas is damaged and the pancreas isn't able to keep up, and that leads to an inadequate insulin secretion from beta cells. So it starts with insulin resistance, where it just doesn't work well, but then over time that leads to the body's inability to actually produce enough insulin from beta cells. If you look at the second picture over here, this is showing us kind of this blue line is showing us the body's ability to secrete insulin, right? The pancreas's ability to secrete insulin, and it's producing insulin fine over here at the start, right? This is like normal, no problems. We produce enough insulin just fine. But then as it progresses, you can see that the body's ability to produce enough insulin is going down, down, down to where eventually it can't produce any. This first thing here is just what we call impaired glucose tolerance. Typically, if you give the body a big dose of glucose, it should be able to process it. It should be able to convert it into glycogen in the liver and put it into our cells, and we should be able to bring that level down. Somebody who has impaired glucose tolerance, when you give them a big dose of glucose, they're not able to do that well. It's harder for them to process that glucose and get it out of the bloodstream. At that point, we can generally manage people with diet, but you do see that, if this continues, their ability to produce enough insulin is going down. That progresses normally, 0 to 5 years. Patients are here now in the type 2 diabetes range. And during those first, up to about 5 years, 0 to 5 years, we generally treat patients with diet plus metformin, which is an oral tablet. It's called biquinide. But you can see the body's ability to make enough insulin is still decreasing, right? It's going down and down and down. So generally between 5 and 15 years, the medications that we need to use are increasing from here. We might need to add a dose of insulin on board to their therapy. At the end here, you see this last little column here. The body is not producing insulin any longer, even though it's type 2 diabetes. The body's not able to produce insulin, and at that point, patients require multiple daily injections of insulin. Okay, so on this slide, you see a treatment algorithm that shows you the steps necessary to treat type 2 diabetes. Type 1 diabetes, remember, requires insulin injections, basal insulin, and then bolus insulin after meals from the beginning. So type 1 diabetics, you go straight to insulin. Type 2 diabetes mellitus can usually be managed with diet changes, lifestyle modifications like exercise, and oral glucose lowering therapy. Eventually, it might progress to needing insulin, but we don't usually start there. We start generally with something called metformin, which is a biquinide. We'll talk about metformin in part 2 of the series. Okay, so again, this is the algorithm or stepwise approach for treating type 2 diabetes. Up top here, it has, patients have diabetes if their hemoglobin A1C, HbA1c, hemoglobin A1c is less than 7%. Our goal for patients is to have, they have diabetes if it's greater than that. Our goal is to have patients less than 7%. That's generally considered the goal. There are some patient-specific characteristics, some situations where patients are at high risk and we want them less than 6.5, or some situations like an elderly, frail patients where you're really worried about hypoglycemia. We might not be as strict with that. But in general, we're shooting for an HbA1c less than 7%. Remember that using the hemoglobin A1c allows us to look at the average blood glucose over the course of 3 months. So that's beneficial versus, say doing a serum glucose. Serum glucose tells us what the glucose is at that one moment in time, but it doesn't give us the overall approach. Serum glucose can be helpful when we're figuring out what dose of insulin to use, after a meal, or when we're trying to make little adjustments in insulin dosage, or when we're worried about hypoglycemia or whatever. But when we're making overall treatment decisions and evaluating the overall control of diabetes, the hemoglobin A1c gives us a good picture of the patient overall. Now, to begin with, we generally will start a patient on metformin, and we titrate that metformin up to the maximum tolerated dose. Up to the max dose. So metformin is generally our go-to first drug that we use for patients with type 2 diabetes. And last, like if the patient has a absolute contraindication or some intolerance to metformin, but otherwise almost all patients are going to be started on metformin. Then again, you titrate them up to the max tolerated dose, up to the maximum. And then in 3 months, you're going to check the hemoglobin A1c. You need to wait 3 months in order to let the A1c adjust to the medication. If you only wait, 1 month, that hemoglobin A1c is going to reflect 1 month's worth of with the drug, but 2 months worth of glucose without it. So that's not going to give you an accurate picture of how well the drug is working. You need to wait 3 months. Then look, is the patient at goal, right? Whatever the goal is, generally less than 7%. If so, continue that metformin and emphasize diet and lifestyle modifications, which are extremely important in patients with diabetes. If the patient's not at goal, you're already at the maximum amount of metformin that they can tolerate. So at that point, you would need to add another oral agent, which we'll talk about. There are multiple other oral agents, or a GLP-1 agonist. A GLP-1 agonist, we'll talk about it in part 2 as well. This is injectable or very effective and a good agent to add on to that metformin. Wait 3 months and then check, are they at goal or not? If they're at goal, again, continue emphasizing, adherence, lifestyle modifications, exercise, diet, etc. If they're not at goal, then, add another agent or add a GLP-1 agonist, and we continue in this fashion. Also, you could consider adding, once they're on the metformin, if they are not able to get at goal, you can consider adding basal insulin. Most patients, aren't happy about using anything injectable. However, it is an option to add basal insulin on at any of these steps. Okay, so we have our overview of diabetes. You guys can compare and contrast type 1 and type 2 diabetes. You know what your overall goals for treatment are, and the general kind of treatment approach or algorithm. The rest of this part 1 lecture is going to be focused on insulin. We have all different types of insulin that we can give to patients. They differ in their pharmacokinetic profiles. So we'll talk about these and talk about how we use these. All the other drugs will be covered in part 2. So insulin is synthesized as something called proinsulin. And so like if you look at this picture here, you can see there's this blue component and then there's this green component, and they're attached to each other. That's the proinsulin. Proinsulin gets cleaved or split into insulin and C-peptide. So like for every unit of insulin, there's going to be a unit of C-peptide as well. Serum C-peptide is something we can test for. So testing serum C-peptide gives us the best indication of insulin production. And you might think, well, why not just test blood sugar, right? But blood sugar doesn't necessarily correlate with how much insulin the person can actually produce, because remember, they might be insulin resistant. So somebody could have a really, really high blood sugar. That doesn't mean they're not making insulin. It means they are insulin resistant. So the insulin that they're making is not working very well. So serum C-peptide tells us how much insulin is actually being produced. Insulin, right, that we give to patients can be produced, human insulin can be produced via recombinant DNA technology. What we do is we take the gene for insulin, like the DNA that codes for insulin, and we insert that into like E. coli bacteria or into yeast. And then all of a sudden that E. coli now, in its genetic profile, E. coli has the gene for insulin and it starts producing that. Now we can modify, the amino acid sequence in insulin. We can modify that insulin in order to produce various different insulin analogs. And that's how we get all the different types of insulin that have, various differences in like how their duration of action or how long it takes to get to peak, etc. And this is important because remember when you look at the way that insulin is normally released, there's a basal insulin that's steady all the time, right? 24 hours a day. But then when you eat, there's a big peak in insulin, and then it kind of stays high for a little while. When we give a patient insulin, we're trying to mimic what the body would normally do. So we need to give the patient something that gives us a nice, stable, steady basal, and we need to give them at mealtime, we need to give them those peaks, the really, short-acting, fast-acting, but short-acting insulins. So by altering, amino acids in that sequence and then inserting that new gene into the E. coli, that E. coli or that yeast then starts producing this other product for us that's a little bit different. Looking at the bottom, you can see all the different types of insulin that we have. There is inhaled insulin, which is generally not recommended, but I'll talk to you guys about that a little bit. The rest of these are injected. The insulins are generally injected into the subcutaneous tissue. Everything from insulin aspart, degludec, Vladimir, glargine, etc. And NPR. The mechanism of action for insulin, insulin is exogenous insulin, meaning insulin from outside the body is injected into the body in order to replace natural insulin secretion or to supplement, give a little bit more natural insulin secretion. So again, all we're trying to do is just replace what the body should be doing. That's it. Typically, insulin is administered via a subcutaneous injection. Again, there is a such thing as inhaled insulin. However, it's generally not recommended. It's not nearly as predictable as the injected insulin is. So generally what we recommend is insulin to be injected subcutaneously. In diabetic ketoacidosis, DKA, insulin can be given IV. And like this is what you see on here too. Regular insulin can be given IV in hyperglycemic emergencies. Again, DKA. Because the insulin is being injected, technique is very important. If you look here at this picture, there's a couple important things here. One, this is showing us subcutaneous tissue is fat, right? Adipose tissue. So the patient wants to be injecting this into the fat that's right underneath the skin. We don't want it to go into the muscle. That will alter how it gets absorbed, but that can also, alter metabolism in that muscle. So here in this first picture, you can see the person is just pinching up the fat to remove it from the muscle underneath, and that gives them like a little pouch of tissue to inject into. Patients need to be careful not to pinch so deeply that they pull up the muscle. They should not be pulling the muscle, just the fat that's right underneath the skin. This area here, these pictures that show the body, these are showing good areas to inject insulin. These are areas where there generally is some fat tissue available. The abdomen, the belly is a good area. The top of the butt, bottom of the back is another good area. Thighs are possibilities. The stomach is a really common area to use. It is incredibly important that patients know they need to rotate the injection site. So, if you inject in, you can go in the abdomen, you can go in quadrants. So like upper right, then move to the upper left, lower right, and make your way around the abdomen. But it is important to rotate the injection site. And I'll talk about why that is when we look at the adverse drug effects. So technique is really important. There are insulin pens available for patients who have difficulty with technique. Insulin pens are really easy to use because, one, measuring it out, you don't have to, measure it out in the syringe. There's just a little dial that you twist to the right dose, and it automatically measures that for you. And then the pen is just, pushed down into the tissue and it injects the medication. It does it at the right depth. It's very easy to use. Insulin pens are more expensive though. So that's a trade-off. They're more pricey, but they are easier to use. So it's more likely that the patient will use it correctly. This is good, especially in like elderly patients that might be a little bit shaky or, don't have as good fine motor skills. Most insulin is what we call U100. What that means is there are 100 units of insulin. That's how we measure insulin, is by the units. There are 100 units per milliliter. So when we talk about dosing, like normally if we're talking about tablets, we would say, 25 milligrams per tablet. So if you wanted the patient to take 25 milligrams, they would take one tablet. In this case, instead of milligrams, we're using units. So you would say patient needs to inject 30 units of insulin. So then in order to know how to get those 30 units, you have to convert that to a volume. So if there's 100 units in 1 ml, 30 units would be 0.3 mLs. So the patient would need to inject 0.3 milliliters to get those 30 units. There are more concentrated forms of insulin available. So in patients who have to inject very large doses of insulin, it might be beneficial to prescribe them a more concentrated form. That way they're not injecting such a large volume of fluid. For example, there's U200. Sorry, my screen, the writing is very sketchy. But there's U200. That means there's 200 units per milliliter. There's U300. Again, that's 300 units per milliliter. There's also a U500. That is very concentrated. One thing that's important, is to make sure you don't mix these up. Make sure patients understand the differences and the strengths. Because if you are used to getting the U100 and you get the U200, you don't realize you're getting twice the dose of insulin. You might still only inject, 0.5 milliliters, but that's going to give you twice the actual dose. Insulin can also be administered via continuous subcutaneous infusion. So this is what we're talking about, like when somebody says they have an insulin pump, that insulin pump is giving them a continuous subcutaneous infusion of insulin. This allows us to most closely mimic what the pancreas naturally does. Because remember, the pancreas gives us constant basal insulin. Then when we have a meal, it peaks. So with the insulin pump, you can set it for that constant basal infusion, and then every time the patient eats, they program a bolus. So there will be that bolus of insulin to mimic that postprandial insulin. So continuous infusion via an insulin pump is the best way to get as close as we can to what the body naturally does. Also means that the person has to have that catheter placed and have the insulin pump, which can be a little bit precarious. Adverse drug effects of insulin. The most kind of obvious, I think, and common adverse drug effect of insulin is just if the person has too much insulin, right? So they can experience hypoglycemia, and then all of the signs and symptoms that are associated with hypoglycemia. So hypoglycemia, just because the insulin lowers blood glucose, that's what it does. So if the person has too much insulin, they're going to lower their blood glucose too much. Or say, somebody's about to eat, so they give themselves their preprandial injection, their mealtime injection, and then something comes up and they don't actually get to eat. That can be problematic. Signs and symptoms of hypoglycemia include like shakiness, blurry vision, confusion. We also, with insulins, can see some injection site reactions. Obviously, there is, pain and redness at the injection site. We try and make sure that, sterile or aseptic technique is used so the patients don't get any infections. Insulin can cause weight gain, and this can be problematic sometimes in type 1 diabetics. We see this in teenagers sometimes, where, again, we said type 1 diabetics frequently present as being underweight, but then they take the insulin and they start to gain weight. And I have seen in patients before where they try and skip insulin in order to lose weight, which is obviously very dangerous. So that is something to keep in mind. Also, lipodystrophy. Lipodystrophy is like abnormal fat deposition. So like areas where there's less fat and then the fat accumulates in other areas. So the fat isn't laying nice and smooth like it should. That's one of the reasons why it's so important to rotate the injection site. If you are constantly injecting into that same area, it's going to alter the metabolism of fat in that area, and you're going to, it's going to increase the likelihood of lipodystrophy. rotating the injection site allows you to kind of spread that out, spread those effects out so that it's not one area that's getting pounded all the time. Bronchospasms are possible with inhaled insulin. So again, we don't recommend inhaled insulin anyways, because again, it's not as accurate. We don't have as good, control over it. However, there is don't use it, period. Definitely don't use it in patients who have asthma or COPD. Also, it's not recommended to be used in smokers, in patients who smoke, because that does alter the absorption. As far as insulin goes, we do decrease the dose of insulin in renal insufficiency. And then you can see, other adverse drug effects listed here: headache, tachycardia. Mostly what we're worried about, though, is the hypoglycemia and then everything associated with that. Oh, sorry, one thing I wanted to mention is this sweating, guys. Hypoglycemia is associated with sweating, and that is the one effect that is not blocked by beta blockers. Remember, if a patient is on a beta blocker, that can block some of those signs of hypoglycemia, like tachycardia, for example, is blocked by that beta blocker. But the beta blocker does not block the diaphoresis. It does not block that sweating. So even if patients are on beta blockers, sweating is a good indication of hypoglycemia. So we're going to talk in detail about all of the different types of insulin that we have. They vary kinetically, so they all do the same thing. They're all insulin, but they vary in their onset of action. So how long does it take for this insulin to start lowering blood sugar? Their peak, do they have a really high peak, or do they not really peak at all? Are they just stable? And their duration of action. Some insulins are just quick acting. They only work for a short period of time. And some, can last all day. So when we look at insulins, we classify them kind of based on their kinetics. So rapid acting or short acting, moderate acting, long acting, etc. And what we do is typically patients are on multiple different types of insulin, and we pair them together, again, to mimic what the body naturally does. Basal insulin and then peaks at mealtime. And this graph up here shows you, at the top, this graph shows you the onset of action and duration of action of all of the different types of insulin. They're color coded, so like the color that the insulin is in the graph, that's the color that I've made it down on my slides. So rapid acting and short acting insulins. These are the insulins that are like our mealtime bolus, right? When you eat a meal, you get a big peak, doesn't last for that long. The regular insulin is a short-acting insulin. Regular insulin peaks, like it's at its highest point between about 50 and 120 minutes. So for like 1 to 2 hours, regular insulin is at its highest point. When we look at like how do we use it, this is usually given 30 minutes prior to a meal. So administer 30 minutes prior to meal, meaning this is used for mealtime bolus. And you can see it here in blue, right? It comes up to a pretty high peak. So you can see it comes up to a really high peak, doesn't last too long. Out here by 4 hours, it's much lower. Insulin Lispro, insulin aspart, glycine, these are rapid acting insulins. They are still active for just a short period of time, but they actually start working faster than the other agents. So we classify these as rapid acting. Lispro, for example, insulin Lispro peaks at between 30 and 90 minutes. So it's peaking in about half as much time as the regular insulin. So they're active really, really quickly. Inhaled, again, we don't really recommend, but the inhaled powder is peaks in about 45 to 60 minutes, so it's still pretty rapid. The rapid acting is generally, so like insulin Lispro is the common one, is generally administered 15 minutes before a meal or within 15 to 20 minutes after starting a meal. So there's some variability there. We generally give mealtime insulin before the meal. But sometimes you forget, right? If you think of like a kid in high school, for example, and they need to inject before lunchtime. But say they're scheduled for B lunch and that day, last minute, they are told, hey, we got moved up to A lunch. Well, I haven't injected my insulin yet, right? Like, what do? I have to inject 30 minutes before a meal. Well, if they have insulin Lispro, that's fine. They can just inject right then. So insulin Lispro does have some convenience benefits because of the flexibility in dosing, or like rapid acting. When we compare short acting, like regular insulin, to insulin Lispro, this rapid acting insulin might have a slight benefit in controlling glucose. We do see a little benefit there. It does control glucose a little bit better, but it's not a huge difference. The big benefit in this rapid acting instead of regular is just convenience. It's more convenient, more flexible with the timing, but it is more expensive as well. The rapid acting is great, again, at controlling postprandial glucose levels. Also, because the rapid acting agents start working so quickly, you can see how long they peak in about, a half an hour, but it starts going up right away, right? They have a pretty steep slope. So these are good in emergent situations as well. So like anytime you need a quick correction of glucose levels, you could use a rapid acting agent. The rapid acting agents can also be used IV in emergency. I mentioned previously that we generally use regular insulin. So regular insulin is used for postprandial glucose control, and regular insulin can be used IV for emergencies like DKA, like diabetic ketoacidosis. We can also use the rapid acting agents though. So again, usually we use regular insulin, but the rapid acting agents can be used too. Rapid acting agents are very commonly used in pumps as well. So on this slide, we have intermediate acting, like kind of moderate in the middle insulins, and then we have the longer acting agents or long acting insulins as well. NPH insulin, NPH, it stands for neutral protamine agonist. We just call it NPH. This is one of the original insulins. Insulin R and insulin and NPH insulin are like the two kind of old insulins that we have. This is again intermediate acting, so it's used for basal control of glucose, but it doesn't last all day, so it does require twice daily dosing. If you look up here at this orange line, you can see it takes a while to build up, and then it kind of slowly goes down. It's just not very soluble. So when it gets injected, it takes a while before it actually like leaves and goes off into the bloodstream. Because it takes so long to start working, right? You can see like 4 hours before it peaks, but in this slope here is not very steep. So we do not use it for emergencies. So NPH is not used for like DKA or anything like that. It's just twice a day for that basal control. However, if you look at the shape of this, that does not look like what our basal control looks like, right? Remember, our basal insulin release is very flat. So if we administer this twice a day, it's going to kind of look something like this. Not a huge peak, but still not exactly like our basal insulin. Then we have the long-acting agents. Long-acting agents are good for basal control of glucose. These are the best agents to mimic what our body naturally does for basal control. They are used, generally used once a day. Insulin detamere. Insulin detamere has a fatty acid side chain on it. So it binds to get solubility in the blood, it binds to plasma proteins. It specifically binds to albumin. And then it, slowly gets released from albumin and goes and works. So like that protein bound detamere acts kind of like a little like reservoir of the drug, and it slowly gets released. So it results in kind of a flattened, delayed peak and a long duration of action. So that's what you see in green, right? It's pretty flattened out, even more so than we see with the NPH. And again, a pretty long duration of action. The detamere, though, does still require twice daily dosing in most patients. So it's still considered long-acting, but still most patients are going to need BID dosing. Glargine and degludec, though, are nice, flattened out once-a-day dose. Insulin glargine, that's the red that you see. Here, let me erase my drawing. That's the red line. Insulin glargine forms a precipitate, and then it slowly gets released, slowly releases the insulin. So it does have a little bit of a delayed onset. If you look at this, it kind of takes a little, it comes up like that, takes like a half an hour or so, and then you have this really flat, no peak at all, long duration of action. Insulin degludec also has like a slow release over an extended period. It has a really long half-life, no peak at all. Insulin degludec is like, perfectly mimicking what our basal insulin does. These insulins are only used subcutaneously. They're not injected IV or for emergency situations, DKA, any of that. They're just given subcutaneously for basal control of glucose. One thing that is important to keep in mind is that you can't mix detamere or glargine in the same syringe with other insulins. So if a patient has to inject 2 insulins at the same time, like say it's the morning and the person's going to take their basal insulin dose that's going to last all day, and they're going to take their morning mealtime dose, their breakfast dose of insulin. You don't want to inject 2 times. It's easier if you can just draw them both up into the same syringe and only have to inject once, right? And some insulins you can mix just fine. So say the person was on NPH twice a day for their basal, and then they were on insulin R for their mealtime. You can mix those together in the same syringe so that you only have to inject yourself once. Um, if the person is on detamir or glargine, you can't do that. You cannot mix them. They would have to actually give 2 separate injections. Okay, so here you see some possible insulin regimens. And there are various different types of insulin regimens based on the specific drugs that are being used. This first one here is the most similar to our actual insulin release. It's also the most expensive out of all of these, but that's the best one as far as trying to mimic what our body naturally does. You see, insulin glargine or insulin detamir for this basal insulin. Here you see it being injected at bedtime. And then, lasting pretty much throughout the whole day. Then you see there are 3 injections for mealtime insulin, and they're using Lispro, which is the rapid acting insulin. You can see it's injected at breakfast, lunch, and then supper or dinner time. This very, very closely resembles what our body would naturally be doing. This one up top here is a cheaper option, but it's also not, quite what our body does. There's a lot, there's some differences here, which we'll talk about. So this regimen, the person's doing NPH for their basal insulin. Remember, that requires twice daily dosing. So they have their NPH at bedtime, right? That carries them through the night. And then at breakfast, they're injecting NPH again. And you can kind of see, in the background there's the NPH. Their morning injection, they are mixing the NPH and the regular in the same syringe. And that's the 2 colors that you see here in that syringe for breakfast. That's okay to mix those. So the regular insulin R, is what they're using for their mealtime insulin. So breakfast, lunch, and dinner. Notice it kind of lasts a little bit longer than what would naturally happen in us. And their basal insulin has these kind of 2 little peaks there. So it's not exact, but it's a cheaper way to get what we need. And it's still 4 needles, right? 4 injections, 4 times that they have to poke themselves because they're able to mix that breakfast dose in the same syringe. Here on the bottom, this is fewer injections, but it's even further from, what naturally happens in our body. This is somebody using a pre-mixed insulin. There are pre-mixed combinations that allow us to decrease the number of injections. But again, it doesn't mimic what's happening in the body as well, and it makes it harder to adjust doses. Because if they're separate, you can adjust just the basal if you want, or you can adjust just the mealtime, if you want to, based on, their meals. When it comes in a premixed solution, you can't adjust just one, right? If I increased the mealtime, I'm also increasing basal insulin. But here you can see NPH and regular insulin comes together in a 70-30 combo, like 70% NPH for basal, 30% regular. And then you can see that, the person's just injecting that twice daily. They inject it at breakfast and at dinner. That means they don't get to peak for lunch. When you're coming up with a regimen for your patient, there are a few kind of things that you need to think about. First off is your goal for this patient. What's your goal A1C? How strict do you want to be with treatment? There's what we call standard treatment and there's intense treatment. Standard treatment is twice daily injections, so they're not sticking themselves as much. You don't have as tight control of the glucose, so there are more complications. So like increased microvascular complications, there's an increased likelihood that the patient's going to have, retinopathy, neuropathy, kidney issues, etc., because you're not controlling the glucose as tightly. However, because you're not being so strict with your glucose control, there are fewer episodes of hypoglycemia. Hypoglycemia can be very dangerous. If it's severe enough, patients can progress to seizures and coma. Patients get dizzy and more likely to fall when they're hypoglycemic, and falls can be very dangerous in elderly patients. So if you have a patient, who's elderly and frail, it's probably best to go with this standard treatment because one, hypoglycemia is more dangerous in this patient. Two, microvascular complications take time to develop. So if your patient's already very elderly, you're not really worried about long-term complications. You're more worried about the current situation and safety currently. Intense treatment is when patients use, 3 or more injections daily. So like that 4-injection regimen that very closely resembled our natural insulin release, that would be considered intense treatment. This is more likely to have patients achieve that hemoglobin A1C of less than 7%. It's associated with fewer microvascular complications because you're controlling glucose so much better. However, patients do have more episodes of hypoglycemia. Intense treatment is good when you have younger, healthier patients. If your patient is younger and healthier and they have a long life ahead of them, then you really want to protect them from those long-term microvascular complications. If they're newly diagnosed, also a younger patient is more likely to be able to manage those injections better. They're more aware of whether they're getting hypoglycemic or not, and better able to handle that hypoglycemia when it occurs. So intense treatment in general should be avoided in long-standing diabetes. If a patient has had diabetes for 20 years, they probably have already caused these microvascular complications. And at that point, the risk isn't worth the reward. Again, if they already have significant microvascular complications, then what you're trying to avoid is already there, so it's not worth the risk of hypoglycemia. Advanced age, again, I talked about this, elderly patients are more frail, more likely to fall, less likely to be able to manage the hypoglycemia well, and along those same lines, hypoglycemic unawareness. So if the patient is not able to notice the signs of hypoglycemia and manage them appropriately. In a patient who is hypoglycemic, if they have signs of hypoglycemia, they need to immediately check their blood pressure. They should have a machine at home. I'm sorry, not blood pressure. They need to check their blood glucose levels. They should have, test strips at home. And they need to have glucose tablets available so that they can, chew a glucose tablet. And they should always have them with them if they're on insulin. So if your patient is not able to notice that and manage that, then they should be on the standard treatment where there's less risk for hypoglycemia. So this here is again just kind of comparing standard therapy to intense therapy. And same thing that we were just talking about. When you look at hypoglycemia, there's more hypoglycemia when you have intense therapy, but there's fewer microvascular complications. So you just have to look at your specific patient and decide which is best. Which insulins to use, it's also going to be patient specific. How many injections a day are you trying to shoot for? What insulins are covered in your patient's insurance? How tight control do you need? What can they afford, etc. And then the last thing is the actual insulin dosing. The insulin dosing will generally be weight-based to begin with. I'll do an exercise. I'll post an exercise with you guys where you calculate the insulin dose based on the patient's weight, and then you break that total daily dose up into basal insulin. You take the units and you break it up into a basal insulin and then mealtime insulin. And then you can, go from there. If your basal insulin is, one injection, great. If you're using NPH and it's 2, you split it up. And then your mealtime insulin, same thing. You would split that up between the 3 meals of the day. But I'll post an exercise for you guys to do that. Okay, that is it for insulin. I will come back with part 2 to look at other parenteral or other injectable agents that we use for diabetes, like the GLP-1 agonists, as well as oral diabetes medications like metformin.